replacement in an outpatient setting. So everyone's gearing up for this. It's growing. It's been going on a few years, but it's really starting to take off at this point. Now, our experience here at the Andrews Institute, to explain a little bit more about what we are, we're a freestanding ASC. We have 8 ORs, and we don't have any options for keeping people overnight. It's pure outpatient, so we have to be able to discharge them. So we're going to talk about how we go about that. We did our first total knee in 2015. Since then, we've actually done a couple more, so we've done 178 total knees since December of 2015. We've done uni knees and total shoulders since about 2010, and then we've been doing total hips for the last couple of years. So we're doing about everything. We've done total ankles also. So that's what we're doing in an outpatient setting. And so back to total knees, what are our keys in doing outpatient total knees? So I'm going to walk you through our process, our program. Some of the very important keys are, number one, is patient selection. Patient selection is absolutely critical. Our multimodal anesthesia, analgesia approach to managing these patients is important as far as their anesthesia and pain management expectations go. And then, as Dr. Berger said, setting expectations for these people are very, very important, because this, as you guys have all seen, is a major, major surgery, and it's very, very common. So for our selection criteria, we have a very specific set of criteria of age less than 70, an ASA of 1 or 2. That would obviously be well-controlled comorbidities. Hemoglobin A1C of less than 7, a BMI of less than 40. The patient has to be physically fit, have no clotting disorders, obviously, and have an acceptable home environment. They also need a very strong support system, and they themselves have to be motivated and have a desire to do this. It's really funny. A major surgery like this, so many patients are so motivated, especially in the year 2020 with COVID, to not be in a hospital setting. And so that may be something else that's actually pushing this year, especially, and more people being interested in outpatient total joints. And while we actually have quite a crowd tonight, I understand we had over 600 registrants for this meeting. So obviously there's a lot of interest. Obviously, again, no pain management issues and no substance abuse issues to be able to do this on an outpatient setting. And it's got to be just a straightforward total joint, nothing fancy, no revisions or anything like that. All our total joints patients meet with our total joint navigator and anesthesia for a face-to-face appointment. Our total joint navigator is critical. We have a nurse, a master's degree nurse, that is specifically hired to navigate these patients through our system. And we'll talk a little bit more about what she does. As far as our protocols go, the patient has to be scheduled at least 3 weeks prior to the day of surgery. They have to be seen by their PCP for pre-op testing labs and clearance within 30 days of the surgery. And they have to come to the ASC to meet with our total joint navigator and our anesthesiologist within 10 days of surgery. They must have their lab results and bring them with them, or we have to have them accumulated by the total joint navigator for the anesthesiologist to review on that day when they come in. Our required labs that we go with, if they're smokers, we want a chest x-ray. We're going to get an EKG. We're going to check a CBC and a platelet because we're doing regional anesthesia. We're going to check the INR and then a metabolic profile. All this lab work needs to be within 30 days prior to the surgery. Now, when our patient comes in to meet with our joint navigator, our nurse, here's the things she's going to do with our patients. She's going to get an accurate height and weight and get a specific BMI, so we know our BMI is correct and under our limits. Our navigator is going to do our pain pump teaching and a hands-on demonstration of our catheter and our pump. She's going to show them the catheter we're going to put in. She's going to show them our pump and explain exactly how it works. And then when the anesthesiologist meets with the patient, we'll go over that again briefly so the patient has a good understanding. Patient education, and for our continuous catheters, we do quite a bit of those here for lots of different surgeries, is critical. But then the total joints is just critical. They have so many things to know about PT and pain pumps and medicines and recovery, that patient education is a critical factor and a major point that we stress here. They're going to get crutch and walker training, crutch or walker training the day they're here with our total joint navigator. They're going to get reminders and teaching. She's going to go over everything in every detail. Specific surgeon discharge instructions will be gone over by her and explain all the different things the patient should be aware of. And what's nice, they actually come in for their face-to-face, but they also get a walkthrough through our ASC. They get to see what we're doing, see where the pre-op area, where the PACU is. They get a little more comfortable with our setting, and we feel like that helps them. Them and their caregiver get to come through and see our situation and answer lots of questions that they may have, just so that they're more comfortable when they come back for their surgery. And then, of course, the anesthesiologist will sit down with them, be face-to-face, go over the anesthetics, the femoral catheter, the femoral triangle catheter we'll be putting in, and the IPAC block that we're going to talk about, and make sure the patient's comfortable with all that before they come back for surgery. Now, arthroplasty ERAS, there's a nice study done by a hospital for special surgery in New York, and they looked at 9 components with over 1.5 million patients. And their conclusion was the more components that your system did in these 9 ERAS components, the better outcomes they had. And when I looked at this, when I found this article and I looked at this, I said, we're doing every single one of these things. So we have a regional anesthetic. We're doing spinal anesthetics. We have multimodal analgesia. The patients are getting TXA. All our total joints get 2 grams of tranexamic acid. We give them an antiemetic. We give them Zofran and Decadron the day of surgery. They get dexamethasone. We have physical therapists see our patients after discharge from a recovery room. We have a physical therapist that goes over their therapy needs for the first couple of days and what it's like going home and transferring to and from the car. And that is something that we've just started recently, been a major factor in helping our patients. As a matter of fact, Dr. Thomas and I, our day has been about total joints. We started with a 6 o'clock meeting this morning with our total joint team. And all of our surgeons were either there or on the phone, and our total joint navigator. And we meet quarterly and discuss any issues. So that's another important factor that goes along with our program. We obviously don't put any Foley catheters in. We don't do it intra-op. We certainly not going to send them home with one. You could, but we don't want to do that. Obviously, we really minimize our narcotics with our multimodal program. So we're not going to do PCAs, and we're not going to have drains in our patients for our total joints going home. So let's get into our multimodal management for our total knees. And what do we do preoperatively? So they come in pre-op into your pre-op area. They get their gown on. They get changed. They get the IV started. And we're going to give them a Valium, 10 milligram Valium. We really like the muscle relaxation effect of the Valium and the sedation. Help get these patients relaxed. But also, again, we like it as a muscle relaxer. We're going to start with our multimodal approach and give them PO gabapentin and a gram of acetaminophen. And then we're going to give them a little more sedation if they need it with some IV midazolam. And we'll do our IPAC block. And then we're going to do our femoral triangle catheter. And of course, they're both going to be ultrasound guided. And that's preoperatively. Once we get into the OR, we're going to do a spinal anesthetic. We'll give them their TXA. They get Decadron 8 milligrams, and then we get back into multimodal effect with Ketorolac 30 milligrams, ketamine 15 milligrams. Sometimes we'll cut the Cadorlac down to 15 milligrams. And then we give Robaxin 1 gram IV. A lot of time, most of the time, since I'm doing a spinal anesthetic, I'll save that and give that in the PACU. And these total knee patients have a lot of posterior pain. They have a lot of hamstring spasms. And we found that the Robaxin has been extremely helpful. And by giving this IV in the PACU or intraoperatively. We also put on SCDs for DVT prevention also. Now, postoperatively, when the patient goes home, we continue that Robaxin for 2 to 3 days, 750 QID for 2 to 3 days to help with that first couple to 3 days of hamstring spasms that they'll get with a total knee. We stick with our gabapentin or pregabalin for a couple of weeks, and we keep them on a nonsteroidal for about 30 days. If they're on a nonsteroidal that they're taking at home, we'll have them continue that. If they're not on one, we'll put them on some celecoxib daily for up to 30 days. Then we have our femoral triangle catheter, and that's going to be in for 4 days. And they'll have a pump. We're going to talk a little bit more about that. And they discontinue their catheter and throw the catheter away and send their pump back in or throw the pump away. The last thing they're going to have that we're going to recommend their use is hydrocodone or oxycodone that their surgeon has written for them. We're going to try to minimize our narcotics, use a multimodal approach, and we've had some really good success with this approach. Now, our surgeons, a couple of things that come into play with them. When we first started, the first surgeon that did the first total knee here back in 2015, he had read some literature that patients did better and had less pain if they did not use the tourniquet. So he did his without a tourniquet, and most of our surgeons still use the tourniquet, but that's another factor. If your surgeons don't, that could decrease your pain risk. The other thing we've been using in our program this year, our surgeons are using the Smith & Nephew robot. We started with a Navio robot, and now they're using what's called the Corey robot. It's which stands for Center of Real Intelligence. And what this does, this takes a 3D model of the joint anatomy that's created from their pre-op CT scan. And this allows the surgeons to get their cuts on the tibia and the femur to very, very, very precise cuts to within 1 to 2 millimeters of what they're desired. It's a really a little different. I think you guys are all used to seeing a surgeon get their blade and cut through the bone, and those are, they try to get those as precise as possible. But with the robot system, and there are different companies that make different ones. We just have gone with the Smith & Nephew product. What they do is, instead of cutting with a knife and taking a blade and cutting through, they actually use a burr, and this burr just kind of shaves down the femur. And they're looking on the computer screen, and it shows you the condyle here, and the different colors as they get deeper with their cuts. The colors change, and so they can precisely get them to within a millimeter of where they want to be. So here's another image of the computer image, and you see white, green, purple, and that's different depths of cut, and they'll end up shaving in this area with their burr and shave down to where this is all the same color, the exact depth of shaving that they want to do, so that they get their alignment better and better fit for their prosthesis. So let's talk about the femoral triangle catheter, and I'll talk a little bit. It's basically an adductor canal catheter that we come up a little more proximally, and it's very simple. We're doing the same thing. We're doing it proximally, and then we come in a little bit of an oblique approach. And before we get into that, we'll talk about the evolution in my practice in the last 30 years. The evolution of pain management for total knees. And when I was a resident, pretty much we were doing just narcotics. And then when I finished my residency, we started an acute pain service. I trained at UAB. I stayed there on staff for a year, and we started acute pain service, and we started doing continuous lumbar epidurals in a 3-day hospital stay. Then we moved on, after many years of that, in the 2000s, we started doing femoral nerve blocks. Then we went to femoral nerve catheters. Adductor canal catheters came along in 2012 to decrease that femoral block and the quad weakness you get with a femoral catheter and femoral blocks. And then we moved up a little more proximally up the leg just 2 or 3 years ago with the femoral triangle catheter. And we'll talk about that now. That's the cornerstone of our multimodal post-op analgesia. Regional anesthesia, analgesia, and continuous catheters, I think, are the cornerstone of really what you build everything else around. And how we do it, we start with an initial bolus of 20 cc's of Ropi 0.2%, ropivacaine 0.2%. We use that so that we don't, if we do get up close to the femoral nerve, we don't want to get quad weakness. And then we send them home with a pump. It's an electronic pump that runs bupivacaine 0.125%. And what our pump, the way we've got our pumps running in the last couple of years, we use an intermittent bolus, which gives an 8 cc bolus every 4 hours, and we run this catheter for 4 days. The patients are allowed a demand bolus, which they can do every 2 hours. So if it gives them a regular intermittent bolus, 2 hours later, they can give another demand bolus while they're waiting on their other intermittent bolus coming at 4 hours, and it's going to come automatically. So the patients still have basically a PCA regional anesthesia technique where they can give themselves their own boluses if needed. They discontinue their own catheter. We leave them in 4 days. We were leaving catheters in 3 days. And I talked to a few years ago, we talked to our recovery room nurses, and we asked them, said, how are they doing on that 4th day when that catheter's out? And they said, there's still a good bit of pain there. So we moved it up to 4 days. Some people think you should leave it in 5 days. But I can tell you a 3, 4, or 5 day catheter is much better than a 18 to 24 hour single shot block when you're talking about an invasive surgery that's as painful as a total knee. And to send these patients home, we have to treat them for more than just a day. And if we're going to be pain management specialists and be really involved. And your surgeons really appreciate that if you take that into consideration and you work hard to help them do a successful program. And like I said, the patients pull their own catheter. It's real easy. They just throw it away. They return their pumps in a self-address box that we give them, and that's pretty easy. So let's talk about adductor canal blocks and shift that into a femoral triangle block. So we started doing adductor canal blocks after reading a letter to the editor by Bansui a few years ago, and he showed where you have the sartorius in the mid-thigh, and right in the middle of the sartorius is the artery and vein, and the saphenous nerve sitting right next to the artery, next to the sartorius. This being anterior lateral, this being posterior medial. And so when we're doing this, we're talking mid-thigh. We're talking about halfway between the knee and the hip, the mid-thigh. You can see the sartorius here and our artery right in the middle of the sartorius. So that's more or less where most people do an adductor canal block. And again, from the other side of the leg, you can see we're mid-thigh right there between the knee and the hip. So when you're in the mid-thigh, you see the sartorius here, and you see the artery, and you see the saphenous nerve sitting up here next to the artery. The nerve to the vastus medialis is away from the saphenous at this point. Matter of fact, it's about to leave and go right into the vastus medialis muscle here. So if you're blocking here, you're not exactly getting the nerve to the vastus. If you're blocking here, you're not exactly getting the saphenous. For total knee, we really like to get both of these nerves. The nerve to the vastus medialis goes down to the anterior capsule of the knee, and the saphenous nerve comes down and gives branches to the medial side of the knee. So I'm going to show you some videos to explain this anatomy a little bit more. This is so here we are. You can see the sartorius, the artery. Here's our saphenous nerve. Here's our nerve to the vastus medialis. And we're going distally now. We started mid-thigh and we're sliding distally. And you're going to see this nerve to the vastus go right out into the muscle here, right there. So at this point, if you come down here, you're totally going to miss the nerve to the vastus medialis if you come in and block the saphenous nerve at this point. Now let's go more proximally and let's look at our nerves as we go up. At that time, we were going with our probe. We were starting mid-thigh here and going distally. Now we're going to go more proximally and see what the nerves do. So here's your artery, femoral artery. Here's your vein. Here's the saphenous nerve. Nerve to the vastus is out here. As we go proximally, the artery is going to shift more posterior medial. And the nerve to the vastus here is going to come in closer to the saphenous nerve. And we're going more proximal and more proximal with our probe. And now I think you can see that you've got the artery way posterior medial behind the sartorius. So we're going to come in from the anterior thigh and come in through the sartorius, put our needle in here where we have both the saphenous and the nerve to the vastus medialis here in close proximation to each other. And we feel like we get a better block of both nerves that way. We always use a nerve stimulator so we can actually get the stimulation of the nerve to the vastus and know if we're close to that nerve or not. We'll get the stimulation. Okay, that's what we just showed. So we're getting up to the femoral triangle. When we get up to the femoral triangle, you see the sartorius, the artery, the vein, the saphenous nerve, and the nerve to the vastus here. That's your femoral triangle. Also, we're going to show you a little deeper view where you have the sartorius, the adductor longus, and the vastus medialis. Deep to that's going to be the femur, sorry, not the finger, but the femur. And here's your triangle, your femoral triangle, the sartorius, adductor longus, vastus medialis. Inside of that is going to be the femoral artery and the saphenous nerve and nerve to the vastus medialis right here. Since your ultrasounds don't come labeled like that, we'll show it to you again. Again, this is a deeper look to show you the femur. Sorry about that. I just went too far. Here we go. To show you the femur, the vastus medialis muscle, the adductor longus, and the sartorius. Now, if you go up even higher, I'm going to show you where the saphenous and nerve to vastus actually come from. They come from the femoral nerve. And we go up a little higher, we can show you the femoral nerve here, next to the femoral artery. And as we're scanning distally from the femoral nerve, you're going to see this femoral nerve break up usually into like 3 pieces. And that medial piece next to the artery is the nerve to the vastus and the saphenous nerve. And they're right here. And as you come on down the leg, now you can see the sartorius forming. You still have the femoral artery, and we still have the saphenous nerve and the nerve to the vastus. They've actually split up now from that medial portion of the femoral nerve, and then you go on down the leg, and they're going to separate even further as we go. So we're up high here in the femoral triangle, and so a lot of people are concerned about, getting a femoral block. And that's why one of the reasons we start with 0.2 Ropi for our initial block, and then we use 0.125 bupivacaine in our pumps with very low concentrations to minimize the motor block. And of all these that I've done, I've only had one patient that really got quad weakness from their continuous catheter. And that just happened about a month, 6 weeks ago. And but with our concentrations and their volumes, we haven't really had that problem. I know that's a concern a lot of people have. So back to show you, this is the mid-thigh or adductor canal block. You can see our marks here. That's where we're going to do the femoral triangle block. So you can tell it's much more proximal. It's really pretty close almost to doing a femoral nerve block, but you're more distal. You're below the crease of the leg, whereas a femoral nerve block is between the crease of the leg and the inguinal ligament. So we're up in here. That's adductor canal. Here's a block look from the other side. Now this is our femoral triangle approach. And the other thing you can notice is we've got the probe a little bit of an oblique angle here. And that's because we're going to come in from this approach from lateral to medial. And when we start to thread our catheter, we're going to have our bevel pointed distally so we can thread the catheter down the canal parallel to the two nerves. And that way, if it pulls back a little bit, it's still next to the nerves and it's not going to pull back and pull away from the nerves. Again, you see the sartorius here, and you see how the femoral artery is in the posterior aspect, posterior medial, back down in here. Again, here's our approach. Just giving you another look to give us a little bit of the oblique approach here we're going to come in with. And sartorius, now the artery is flipped over on the other side, and we're going to come through the sartorius. And actually, I want to show you a video of that right now. So here's our sartorius, here's our artery, here's our saphenous nerve, nerve to the vastus. Here comes our needle. We're getting a little muscle twitch, muscle stimulation. The key is you want to pop through the fascial plane of the sartorius, and you want to get your injection deep to the sartorius muscle down in here where the nerves are hanging out, down in this area. So you can see our needle is down here. We'll start injecting, and you'll see local spread in this area here. Very important that it's deep to that sartorius. Don't want to inject into the sartorius muscle. So you can see the spread of local all around here. It's kind of hard to see the nerves sometimes. They get pushed down, they get pushed around. When you're putting local in there, the nerves will move around. They're not going to stay still. So you have to sort of keep an eye on them. Sometimes it's hard to tell what's nerve and what's not. Here's another femoral triangle injection. So our needle's already in. We're through the sartorius. There's our femoral artery, and we're going to inject right here. And again, you see this expansion of local anesthetic. Now this will open up here, and it'll also track proximally and distally up and down the canal where the nerves are running, and get the local. Looks like we might have nerve up in this area, but the local's still getting to it. So coming through the sartorius, always using a stimulating needle just to play it safe, and so that you can find the nerve to the vastus and know exactly where it is. Sometimes it's hard to see. Now, when we thread our catheter in, no way, I went one too far. Here's our catheter. So here's our needle coming in. We've got the bevel pointed down the leg, so the catheter is going to come out, as you just saw there, and then it's going to disappear because it's going to go distally down the leg towards the knee, running alongside the nerves here in that canal. Now we're going to check. We're going to be a little bit further down. Remember, the artery was up here when we did our catheter insertion, so we come a little further down the leg, and the artery is going to move more closer to the middle of the sartorius, almost like where we did the adductor canal injection before. And then we're going to look for our, we're going to inject through the catheter, look for local spread. You'll see it right here. Locals coming out and spreading here. So we know we're deep to the fascia of the sartorius. We're lateral to the artery. We're right here where the nerves are going to be running, coursing down the leg next to the femoral artery and deep to the sartorius. So our catheter is in good location here. Okay, so again, we want to cover the saphenous nerve and the nerve to the vastus medialis. We want to get the anterior capsule of the knee because it's innervated by the nerve to the vastus medialis. That's why it's important to block. The saphenous has an infrapatellar branch that's superficial, and it goes inferior to the knee. So when they're doing a total knee and they make their incision, their initial incision down the middle of the knee, they're going to cut this infrapatellar branch of the saphenous nerve. So every total knee patient is going to have an area of numbness that's just inferior and lateral to the knee because they cut through that branch as they made their initial incision. We like going up to the femoral triangle versus an adductor canal or a mid-thigh femoral, we call them, because we feel like get a little bit better coverage of the nerve to the vastus medialis. Also, when we were doing mid-thigh adductor canal blocks and catheters, we had a few patients that had a saphenous neuropathy, which consisted of numbness and pain, tingling, burning from the knee to the ankle. And we have found that moving up more proximally in the femoral triangle, that has basically gone away. We've hardly seen that maybe once since we made that change. So if you've seen that with your adductor canal blocks, this is something that might be helpful to come a little more proximal, get in the femoral triangle to avoid that saphenous neuropathy. Again, we always use a nerve stimulator. It just helps you. It helps you identify the nerve to the vastus medialis. Obviously, it won't help you identify the saphenous nerve because it's completely a sensory nerve and there's no motor function to the saphenous. Be a little careful though. You can actually get a twitch, a vastus medialis twitch when you're still in the sartorius. So be very careful and make sure you advance your needle through the sartorius and down into the canal where the nerves are. But that can be a little bit confusing with the nerve stimulator at times. Okay, so that's going to do our anterior medial aspect of pain with our femoral triangle. Now, what about posterior pain? So we all have iPhones and iPads and iPods and this and that. Well, in regional anesthesia, we have our IPAC. So what is an IPAC? So an IPAC is an infiltration between the popliteal artery and the capsule of the knee. So it's very simple, and it was first described by our friend Dr. Sanjay Sina, who's up in Hartford, Connecticut. It was first described at the ASR meeting in 2012. And what Dr. Sina was utilizing this IPAC infiltration for was to block the terminal branches of the obturator and tibial nerves in the posterior aspect of the knee. Therefore sparing the main trunks of the tibial and common peroneal nerves, maintaining a sensory motor function of the leg and foot, therefore just almost completely alleviating the risk of foot drop. Actually, I think I did it. I got a foot drop one time with an IPAC because I got a little too aggressive with my infiltration. I was cheating. I've learned if you stay down and do it the way Dr. Sina described and recommends, you really should not get a foot drop. And certainly in a total knee situation, the surgeon is going to totally freak out if you get a foot drop because he's always worried about the common peroneal nerve, especially if they got a valgus knee and they're trying to straighten it up and they're worried about a stretch of the common peroneal nerve. So we don't want to confuse the issue and cause them to have too many sleepless nights with a situation like that. But what Dr. Sina described is we're basically infiltrating posteriorly to the femur. So you can hear we're right in the knee. There's the patella, the femur, and posteriorly between the femoral nerve. The tibial nerve, popliteal artery and vein between the artery and the capsule of the knee. So it's just an infiltration here to get those branches. Dr. Sina does a medial or an anterior approach where he puts the probe right here and he sees the femur and the femoral artery here, comes down a little distally, and sees, you get this image, and then slides just a little medially, and this is the needle trajectory coming between the femur and the popliteal artery here and vein. So these wants to infiltrate in this way. So that looks like this. You got the knee kind of frog-legged here, and you got, it uses a curvilinear probe, as you can tell on this one, for his medial approach, and the needle's coming straight down down from this approach and infiltrating between the femur and the popliteal artery. Looking at it from the...
Dr. Hickman.
Okay, whoa. I'm going longer than I thought. I'll be done in just a second. So we're coming in with a steep approach here, and you can see we're going to come in between the femur and the artery with the needle coming in this way. So real quick, we actually like the lateral approach where we put the knee up in like we're doing a popliteal block, and we come in and look at it from lateral to medial, just above the knee here. And I'm going to show you, we start with the femoral condyles, and we're going to slide just proximally into where the femur flattens out. You can see the popliteal artery here. You can see we've moved up to the just above the femoral condyles where the femur flattens out. You got the femoral artery, and you got the tibial and peroneal nerves up here. So we can come in and infiltrate along this area, and that's our IPAC block. So show you real quick. Our needle coming in. Let me see if I can advance here. We're going to inject. We use 20 cc's, 1/4% bupivacaine, and infiltrate all along through here. So I see infiltration starting. Come on. There it goes out here. Move along, we'll see some more infiltration. Pull the needle back. We start on the medial side, infiltrate, pull back, infiltrate, pull back, infiltrate. And that's our lateral to medial approach for the IPAC. So our friends over at Ochsner that are getting hammered probably right now by the hurricane, they did a study looking at IPAC on 106 patients. They compared femoral nerve blocks, total knees with femoral nerve blocks versus femoral with IPAC versus adductor canal with IPAC. They showed that the IPAC really works because it reduced the opioid consumption in patients that had a femoral versus the ones that had a femoral with the IPAC block. IPAC with the adductor canals had as good analgesia as the femoral nerve, improved PT performance because they didn't have quad weakening, and they had earlier hospital discharge. So as far as the anesthetic, we'll get to the spinal. I'll try to get in. This is an orthopedic article from the orthopedic literature, the Journal of American Academy of Orthopedic Surgery this year, where they looked at 30-day outcomes of patients, looked at 80,000 spinal anesthetics and 103,000 generals. Bottom line was the general anesthetics were at a greater risk for any complication, major and minor complications, versus spinal anesthetics. So the patients, their conclusion was spinal anesthetics had fewer 30-day complications. And so our data has been in the last few years showing the spinals are better. 10, 20 years ago, we used a lot of generals, but in the last 10 years, our data has shown spinal to be a little bit safer and better for our patients. Obviously, we have the COVID impact of 2020. Most people are leaning towards doing a spinal anesthetic nowadays versus a general, just from that factor alone. What we do, try to wrap up real quick. We do our spinals actually in the pre-op holding area. We use isobaric spinal drugs. We pre-op IV bolus, give IV bolus of 700 to 800 cc's. For our total knees, we use mepivacaine 45 milligrams, isobaric. For our faster uni knees and total hips, we'll use isobaric chloroprocaine 50 to 60 milligrams. And we use a 24 gauge Sprott needle when you've got a patient going home as an outpatient. We certainly don't want the risk of spinal headaches. So our Sprott needle, we're certainly going to decrease our risk by using that approach. I'm not a fan of spinal bupivacaine or heavy bupivacaine or isobaric. Isobaric bupivacaine just lasts way too long. And I think the spinal heavy bupivacaine increases your risk for cardiac and respiratory issues. I had the pleasure of meeting Dr. Sprott here, but a little over a year ago at the Ezra meeting in Spain, and that was quite enjoyable. So sorry we don't have a lot of time for questions, but Scott, do you have any significant questions that would be important? Also, I want to let everybody know that the PAJUNK has a poster for lower limb regional anesthesia. if you want to touch base with your rep, or go to this email here, info@pajunkUSA.com. And questions?
Yeah, thank you, Dr. Hickman. That was a very thorough and interesting talk, so we appreciate that. Reminder, you can submit questions under the Q&A here. We'll try to get to some of them. There are a lot of really, really great questions, and we'll probably run out of time here before we get to them, all of them. But a reminder that you will receive an email link where you can view tonight's webinar on the PAJUNK YouTube channel. And we should be able to answer some of those questions that go unanswered tonight in that forum as well. So let's see, like I said, several good questions. As soon as you put up that slide regarding our preoperative cocktail, there are a lot of questions that popped up regarding concerns for oversedation and any kind of lingering sedative effects in the recovery room. Have you observed that in your practice?
You know, we really have not. And you got to go back to your patient criteria. These are healthy patients. They're not your elderly, weak patients that are frail. These are healthy, aggressive patients that are in great shape. And so since they're outpatients, we have not seen any issues with that. And that's a good question. I would ask that same question. If I was in a hospital setting, then you'd be a little more concerned with that. Good question.
Right. And you've obviously mentioned the benefits of putting catheters in. There's been several questions regarding alternatives to catheters. If your program, for example, doesn't have a catheter capabilities, specifically related to Exparel, and have you had much experience using Exparel for these cases?
You know, not in the femoral triangle or adductor canal. I can't really speak to Exparel. I've tried it probably a couple of times, which is probably not enough experience to really give a good answer. I wasn't real pleased. We've been fortunate. We've been doing catheters here for 13 years and an outpatient basis. And so we've had such good success, and we've had a strong program. We haven't really utilized Exparel that much. We do it some on interscalenes, but not in the lower extremity. Sorry, that's a good question though.
Yeah, and then along those lines, how do you manage a failed catheter in the middle of the night if you do get that phone call at 2 o'clock in the morning? What are some steps you take to manage that patient?
Great question. And that's one of the reasons we do thread that catheter down the canal parallel to the nerve, so that if it does pull back, it stays next to the nerves. That's a key factor on this block. And so that minimizes that. You know, there's not a whole lot you can do. You try to work that patient through the night. You tell them to take whatever PO medicine they may have, whether it be a nonsteroidal, a narcotic, a gabapentinoid. You know, try to get them through the night, ice, and then we will have them come back if we know that catheter, or we feel strongly that catheter is not in the correct position. We will have them meet us first thing in the morning when we get back to the surgery center and evaluate the catheter, bolus it, look at it under ultrasound, and if it's moved completely away from the nerves, we'll take it out and replace that catheter.
Great.
And it's, a lot of people have that fear, and one of the things that limits a catheter program a lot of times, and I've said this over and over, if you really work through it and you have dedicated people, that is a rare scenario. Matter of fact, we keep data, and I think it's, of our patients that actually have to come back to the surgery center, I think it's less than 2% of our patients that actually come back with catheter issues.
I had a question regarding the IPAC. How do you control posterior pain after that IPAC wears off?
Great question, and that's where that Robaxin comes in quite handily, because it really seems to be a lot of spasm-mediated pain and hamstring spasm, and we just seen great results. And I know other groups from Orlando to Orange County that are big on Robaxin too, and they agree that it helps in that factor, because you're right, that's a limited time on the IPAC.
There seems to be a lot of disbelief that we rarely experience quad weakness doing the block that proximally. Do you believe that that's a result of the concentration of the local anesthetic, or the location of the block that prevents that weakness?
I think it's probably a combination of both. It's a good question, and I understand the concern and the question. One thing I do when I inject, very often after I'm done, I love to scan up and down the nerve to see the spread of the local. And it's pretty much any block I do. I've done that for years. And on this one, you are very proximal, and I will scan up and I'll actually see that local spread up to almost the femoral nerve, but it just doesn't ever seem to really get there. And if it does get there, the local just stays on that medial aspect of the femoral nerve where the saphenous and the nerve vastus are. I think doing 0.2% ropey is huge. I think if you used 0.5% bupivacaine, there might be a bigger problem there. I think that's a factor. I think if you're careful, and some people use 10 to 15 cc's in this block, and you can cut your volume down if you're really that concerned about it. If you want to use a higher concentration of a local anesthetic, I would recommend using only 10 to 15 cc's instead of using 20. And I think that's one thing, we get away with it because we're using the 0.2 ropey.
Perfect. A couple of quick ones here. What type of twitch do you see with the vastus medialis stimulation?
You get that medial twitch down the medial thigh, and you'll also, the VMO, which comes up and attaches to the patella, you can actually see a patella snap, both a medial twitch down the thigh and the patella snap. You can see both those with the vastus medialis twitch.
And I don't recall if we addressed this or not, but your block's done pre-op or post-op?
Pre-op. We really do that pre-op. What I like to do, I start with the IPAC, then do the adductor canal, the femoral triangle catheter, and then if we're ready, we'll go ahead and do the spinal in the pre-op area. And if that we got a little time, say it's a second or third case, we'll wait until we're pretty close and get our timing done, and then do our spinal closer to when we're ready to go into the room. But we try on all our post-op analgesia blocks, try to get them in pre-op as most as we can. Sometimes we have a time factor and we have to do them in post-op, but we like to do them pre-op.
Great. I had a question. How long are your surgeons taking for your total joint surgeries on average?
Our total knees, it depends on who you're asking. If you're asking them, it takes like 45 minutes, right? But we end up being in the OR closer to 3 hours because they'll do the surgery and then they leave a PA to close. And sometimes it takes the PA longer to close than it took them to put the implants in. But as a general rule, we're in the operating room with our total knees about 2.5 hours most of the time, probably. And that bupivacaine, I don't know if I mentioned that before, that bupivacaine dose of 45 milligrams, we consistently get about 2.5 hours of anesthetic from that. And that seems to have worked pretty well for us.
Right, I agree. Let's see. Here's one mild source of contention between the two of us here. Do you tunnel your catheter?
So I've been doing catheters for a long, long time. We were putting epidural catheters in, I don't know, 20, 25 years ago. And so back then we tunneled everything. Now the only catheter I tunnel is my interscalene catheter. I do not tunnel femorals or femoral triangle catheters or popliteal or sciatic catheters. The only catheter is that I tunnel still is an interscalene, and as mostly I tunnel it a little bit medially to get away from the surgical area, to get out of the surgeon's way, to get my dressing further away. So I'm not a tunneler like I used to be.
Hopefully most of our surgeons see the benefit in regional anesthesia, but I'm sure some people get pushback from the surgeons a little bit, maybe concerns about infection of an indwelling catheter for a total joint. Do you have maybe some pointers for people to get the buy-in from the surgeons and get them on board with regional?
As far as continuous catheters go?
Or regional in general.
Regional in general. Wow. That has been swinging, I think, the last 10 years. I think the orthopedic, especially the orthopedic training is these guys are being more exposed to regional anesthesia and blocks. I'm guessing the younger orthopods, you're getting more resistance from your older orthopods, and to really, just look at the orthopedic data of spinal anesthetic versus general anesthetic. It's in their literature. They talk about blocks. They talk about femoral blocks at their meetings. It's a hot topic to convince. It's tough if you've got a guy that's kind of been doing orthopedics for 25 years. He's not going to change. My suggestion is work with the younger guys, and really, if you're really just starting out a program and trying to do regional, get one guy on your side, work with one surgeon, get him going, and he'll start talking about the benefits to the other orthopedic surgeons, and then you grow surgeon by surgeon by surgeon. So I would say my biggest recommendation, especially if you're just trying to get it going and get some guys going, start with one and let it grow from there. If you got somebody that's really, really difficult and set in their ways, I don't have any magical recommendations for that. I've just been fortunate to be around guys that have always appreciated what we've done.
Yeah, and I would add to that take ownership of those patients and their pain issues. So if they do have any kind of failed catheter, insist that they call you tonight. In fact, all our patients are provided with our personal cell phone numbers. That may sound scary to a lot of people out there, but we really don't get that many calls. But every catheter patient we send home has complete access to us 24/7. I think the surgeons certainly appreciate that, and the deflecting some of those phone calls in the middle of the night. So as well as complications, any block complications, really try to own those and manage that patient. Don't pawn that off on the surgeon. I think that's been a big part of our success as well.
Absolutely. A great point there, Scott. And one thing Scott and I have tried to do, we if there's a problem with a catheter and the patient's at home, we want the surgeon to never even know there was an issue. We want to get that call, get them back in or whatever we need to do and manage that patient without them even know there was ever a patient problem. And as Scott said, I think if you're successful in that way, you'll get more fans from your surgical colleagues.
Great. I think we have time for one more question. I'll turn it back over to the faculty here. But again, a lot of really, really good questions here, and we'll try to answer some of those via the YouTube channel forum there. Do you have any adjuncts in your spinals, such as epinephrine or narcotics?
I do not. We don't want to use narcotic. I guess you could use a short-acting narcotic, but with these patients going home, we're not using narcotics, and certainly would not use Duramor for any long-acting narcotic. That's one of the reasons I like isobaric local anesthetics. They last a little longer. You don't really need the adjuvants. You don't need epi. And then we use a multimodal approach. So we have not used adjuvants and utilized the isobaric to work for our timing. And I know everybody's got different surgeons that are on different timelines, and you have to work and figure out what works best in your situation, in your practice. So that's a good question.
Great. Well, I think that's all the time we have for questions. Fortunately, we didn't have any power outages here. I'm curious to see what the weather is doing outside, since Dr. Hickman and I have been on lockdown in our offices here. But I'll turn it back over to our faculty here. And thank you all so much for joining us tonight.
Thank you, everyone. I wish I could see you.